Yeah, your PowerPoint is good enough, Dr. Vivek. Just hold for a minute. You are good to go.
Yes,
All
sir.
is well. Just hold. You just don't change any settings. You are fine.
Yes, yes, sir.
Sorry, I don't understand. It's just
ఏమని
I request all of you to mute yourself, please. Those who are participating, faculty and the student resident alone can be in unmute mode. Request you to kindly mute yourself, please. All right. Good evening, friends. Warm welcome to all of you for joining today's postgraduate clinic. So we are today 288 session, and we have one important exam case for the presentation. So we warmly thank Professor G. Subbarao sir, the head of the department at NRI Medical College, and Professor Sushama ma'am for coordinating Dr. Vivek Vrindavan for presenting the case today. I warmly thank Dr. Rahul sir, Dr. Roop Chodhi, Dr. Pankaj and Shanti will be joining shortly. Ishwar sir is also expected to join. I also thank our own faculty, Rajiv Sahay sir, and other senior colleagues who have joined for the day. Today, we have one short presentation. Next week, we'll be having one soft tissue tumor and one vascular case presentation. We also warmly welcome Dr. Kirit Palmer. Pankaj sir, good evening, sir. Uh, so, Dr. Vivek, please introduce yourself, your unit chief, your head of the department, and start your presentation. You will be allowed to present the clinical history part without stopping, and you'll be visited from the slide one to ask questions or give comments. Same way, clinical part you will be presenting without any stoppage. And at the end, you will sum up, and the initial discussion will be based on the treatment, and later we have something more about operative surgery and complications also. Thank you and good wishes for you. All the best. You can start your presentation.
Yes, sir. I'm Dr. Vivek Vrindavanam, postgraduate in Department of General Surgery in NRI Medical College, presenting under the guidance of my unit chief, Professor Dr. G. Subbarao, sir. I thank my professor, Dr. Shivshankar Rao, sir, for allowing me to present in this forum. This is a case of 50-year-old male who is a daily laborer by occupation, hailing from Dugirala, Andhra Pradesh, came to NRI General Hospital with chief complaints of swelling below, in front, and behind the right ear for 10 years. History of present illness. Patient was apparently well 10 years ago when he noticed a swelling below, in front, and behind the right ear lobule, which was insidious in onset and gradually progressed to the present size. There is no history of pain, difficulty in swallowing, or difficulty in opening the mouth. There is no history of increase in size while chewing. There is no history of difficulty in closing eyes, drooling of saliva, or deviation of mouth. There is no history of dryness of mouth, eyes, or joint pains. There is no history of any other swellings in the head and neck region. Past history. No history of similar complaints in the past. There is no history of diabetes, hypertension, tuberculosis, bronchial asthma, cerebrovascular accident, chronic kidney disease, or epilepsy. Patient is not on any medications, and there is no history of irradiation of head and neck region, and no history of previous surgeries in the head and neck region. Personal history. This patient is a non-smoker and non-alcoholic. This patient has normal appetite and takes mixed diet and is having regular bladder and bowel habits. He gets adequate sleep. Patient is married and has 2 children. There is no history of substance abuse. Family history. No other family members suffered from similar complaints in the past. There is no history of malignancies in the family.
Okay, Dr.
End of history, sir.
Yeah. So what do you think you've got by history?
Sir?
Can you summarize your history? Dr. Vivek, can you summarize your history?
Yes, sir. This is a history of a 54-year-old male who came with complaints of swelling in front behind the right ear lobule for 10 years, which is gradually progressive without any features suggestive of malignancy or facial nerve involvement, sir.
So what is the approximate present size now?
This is around 4 into 4 centimeters.
Okay. So why did he come? For 10 years, 4 centimeters swelling. I mean, why did he come? What was for 10 years has not come. Why did he come just suddenly in the recently?
It has been a gradually progressive swelling, sir, but the patient is concerned about it turning malignant, so he presented to the OPD elective.
So it took him 10 years to get concerned.
It was
So
progressive.
did you ask him why has he come? Because it's unusual. A 4 centimeter, which is a very small swelling, for 10 years, and suddenly the patient decides that he should see you. Okay. Let's go to your, that's right. So, history of pain, difficulty in swallowing, and opening of mouth. Why do you take this history? History of pain.
History of pain is to rule out sialadenitis or parotid abscess, sir. Difficulty in swallowing is.
So what about just pain? What about history of fever? If you're thinking of abscess. Look, when you're taking this thing for history for inflammation, take all the history for inflammation. Any change in color, all the 5 stuff of inflammation has to be taken.
Yes, sir.
So you just taken pain and then say that this is for inflammation, isn't it?
Yes, sir.
Yeah.
Onset of pain indicates anything change?
Yes, sir. Recent onset of pain indicates malignant conversion of the tumor from benign.
There is also one point in favor of that.
Yes. Sir.
And what about difficulty in swallowing?
Difficulty in swallowing can be present if there is involvement of deep lobe enlargements.
So deep lobe enlargement obstructs swallowing. How does that happen? Why does the deep lobe affect swallowing?
Deep lobe enlargement can push the tonsillar fossa medially and can cause dysphagia.
So it will be so much that it will obstruct the oropharyngeal opening. Look, swallowing is not a feature of deep lobe enlargement. Not at all.
They could see only bulge there. So hardly any patient complains regarding dysphagia.
Yes, sir.
Right.
What would be the location of the pain? If this patient had pain, where would he feel the pain?
At the site of parotid region, sir.
And can it be referred or radiate somewhere else also?
Yes, sir. It can be referred to the ear, sir.
Which part of the ear?
Outer ear, sir. Anterior-inferior part.
Is it the pinna? Is it the internal ear? Or that is the middle ear? Where the patient complains of pain? Is it in the external auditory meatus?
Yes, sir.
So what would be the pathway if it is referred to the ear? What pathway would it follow?
I'm not sure, sir.
Which is the nerve responsible for that radiation? There has to be some nerve, no? Radiation responsible for the radiation.
Auriculotemporal nerve, sir.
Okay. Where it supplies? Which part of the ear?
Auriculotemporal nerve supplies the parotid gland and parotid region, and it also supplies the pinna, sir.
So does the patient complains of pain to the pinna?
External auditory canal and the pinna, sir.
No. More often it is deep-seated pain comes to the middle ear. No? It is not unusual to the external auditory canal or a pinna.
Yes.
But to the pain is deep-seated pain.
In the history, did you ask about changes in taste sensation? Loss of taste sensation you have not asked here. Right? Can it happen?
Yes, sir.
How does it happen? What is the mechanism for loss of taste sensation, and which part of the tongue would be affected here? Where would you lose
Involvement
that
of
taste sensation?
cauda tympani branch of facial nerve can cause loss of taste sensations.
Which part of the tongue will lose sensation? Posterior 1/3, anterior 2/3, lateral, bottom of the tongue, tip of the tongue.
Not sure, sir.
Not sure. Okay.
Okay, next slide. Okay, just a minute. History of, okay, this is for your facial nerve. Closing of eyes, drooling, or saliva and deviation of mouth. So of this,
Sir, can I
Sir.
ask something?
please, sir, go ahead, all yours.
Okay, thank you. Thank you very much. Have you asked a history of a similar complaint which has regressed on opposite side also?
Yes, sir.
Bilateral swelling?
Yes, sir.
Why did you ask that?
Involvement of other salivary glands enlargement can be
No, I am
seen
talking
in
of parotid. I am talking of opposite parotid. Which parotid swelling will be bilateral?
Warthin's tumor, sir.
Acha, anything else? Something inflammatory? You have asked some about that, I think.
Yes,
In-
sialadenitis is a possibility, sir.
One is a sialoadenitis. What else?
Sir, ladinitis, sir, which etiology can be bilateral? Sir is asking bilateral.
Bilateral.
Infective etiology, sir.
Which one? Infective.
Yes.
Bacterial. Does bacterial cause bilateral sir, ladinitis?
Viral, sir.
It's
Which
viral
one?
more often.
Which one?
Mumps.
Mumps. Yes. Usually mumps, but it is at what age mumps is common?
In childhood, sir.
Childhood. Yes.
Right.
You have written no history of increase in size while chewing. What does it mean?
It indicates it is a feature of salivary colic, sir.
What is
Obstruction
that?
to the parotid duct.
Now you have written increase in size. That is not a colic.
If there is duct obstruction, there is increase in size on chewing, sir.
Chewing. Why on chewing only?
Even the sight and smell of food can cause salivary.
So why you have written specifically chewing?
Right.
Right? It is a right.
Yes,
So, so can there be an increase in size without colic?
yes, sir. Chronic sialadenitis can have increase in size without colics.
Right. So why is it common in parotid to have that colic? Which salivary gland will have a common that kind of what you are calling as a colic or
Submandibular salivary gland.
Why so? Why not in parotid?
Duct obstruction is by stone is more common in submandibular salivary gland.
That's what I am asking. Why it is more common in submandibular salivary gland and not in a parotid?
The secretions are more viscous,
Very
containing
good.
calcium, sir.
Very good. Anything else?
The duct also has a non-dependent drainage.
Very good. Anti-gravity drainage is there and curved and it is hooked by a lingual nerve. So chances of stasis is much more common in submandibular. Have you asked history of toothache or anything? Or any dental treatment?
No, sir.
Yes. Which tooth problem can cause what you are talking about parotid colic?
The vitamin.
Yes.
Caries of the upper molar tooth can cause.
Why?
Parotid duct opening is present opposite the crown of upper second molar tooth, sir.
So
Caries
you
of
have
the tooth can
examined.
cause ascending infection to the
Very good. Okay. So you have described this swelling. What does it mean? In swelling below, in front, and behind right ear lobule. What do you mean by that?
It describes the parotid region, sir.
So the swelling is in all these three regions?
It is the same swelling present below the ear, extending both in front and behind the ear lobule.
So this is a history, not the examination. That's what I am trying to tell you.
Yes, sir.
So the patient has described it like this, that I have got a swelling in front and behind and below ear lobule.
No, sir.
So how do you describe, how the patient will tell you that this is the swelling? This is the examination point rather than history point.
Yes, sir.
So how the patient will describe?
The swelling is present in the upper part of the neck or the cheek, sir.
No, not in neck. It is a part of neck. It is not a part of neck. It is not part of a cheek. So straight away, rather than going in much of a problem, you can very well say parotid region or right ear, around the right ear, like that.
Yes,
Don't
sir.
be too specific. Sometimes it can create a problem because patient is never going to tell you I've got a front, back like that. Why
Yes,
sir
sir.
was asking that patient has suddenly appeared, even though swelling is only 4 centimeter. So in other words, let me ask you very simply, what are the symptoms that will suggest that swelling has become malignant. Parotid swelling has become malignant.
Gradually growing swelling, having rapid increase in size in the
Very
recent
good.
times.
Sudden increase recently. Very good. That's what the sir was asking. You did not take that hint. Same thing. Do you understand? Sir
Yes,
was
sir.
asking why patient has come after 10 years, though the swelling had not suddenly increased in size. That was the indirect inference. Very good. What else?
Recent onset of pain,
Very good. So patient doesn't have a recent onset of pain. 2. Then
involvement of facial nerve, feature suggestive of involvement of facial nerve.
facial nerve. Yes. Anything else?
Lymph node involvement, sir.
Very good. Appearance of the lymph node mass. Earache. Recent earache, which
Yes.
can also suggest that patient can have a problem.
Malignant transformation.
Okay. So why did you ask history of dryness of mouth, eye, and joint pain?
It is to rule out Mikulicz syndrome and Sjogren's syndrome, sir.
Sjogren's syndrome. That's what I was asking. Bilateral parotid swelling.
Yes, sir.
But many times all glands are involved in
Yes.
such cases. Right. And you have no history of any other swelling in head and neck region. What do you mean by that? That's why I ask, have you asked about opposite parotid? What do you mean by that? Any other swelling in head and neck?
Other salivary gland swellings and lymph node swellings.
So they have now disappeared?
No, sir. There were never swellings in other regions of the head and neck, sir.
Okay. Anyway, thank you.
Then family history you asked about. What is the keeping in mind you asked the family history?
Sir?
You asked the family history. No, what particularly you want? Family history of similar swelling.
How is family history significant?
Presence of autoimmune disorders in the family can predispose to Mikulicz or Sjogren's, sir.
Okay, there's one.
Any
reason.
tumors which run in the family? Any tumors?
Tumors among the other parotid tumors.
Not sure, sir.
Any swelling which is can present as a bilateral.
Warthin's tumor, sir.
Yeah,
They
less
have a
tendency for
tendency. That's the one. Okay.
Okay.
Yeah. Okay.
Doctor-
What is head neck? You asked about swellings anywhere else. Why did you ask for the swelling? You just for other parotid or anything else?
Other parotids and lymph nodal swellings, sir.
Only lymph node swelling or any other swellings which, why are you assuming this is just a parotid? It can be a lymph
Exactly.
node.
This can be a lymph nodal swelling, which
Right,
is
so-
reactive or secondary to swellings in the scalp or oral cavities.
Right.
Do you expect
So-
such a long 10 years of history with the lymph nodes to be present there?
Less likely, sir.
Less likely. No. That's why you can exclude that.
Yes, sir.
Dr.
They could
Vivek. Sorry.
Yes, sir.
Dr. Vivek.
Sir,
Why submandibular stones are more common? Because saliva, in case of parotid gland, is more alkaline. Submandibular gland is more alkaline with higher mucus content, and that along with this, there is increased concentration of the calcium and phosphate in
yes,
submandibular gland rather than parotid gland.
yes, sir.
And other causes of bilateral parotid swelling, one more commonest cause nowadays is HIV also.
So what do you think with his history?
This is likely a swelling arising from the parotid gland, sir. Likely benign swellings.
Would you like to put it as a benign swelling? Why?
There are no features suggestive of malignancy as described.
But a recent onset of pain is there, no? Rapid increase in size also.
No, sir.
No,
Mere
sir.
absence of symptoms of facial nerve involvement, does it rules out the possibility of a malignancy?
No, sir.
So it can be there also. So rapid increase in, because they are slow growing tumors generally, it takes around 10 years. But according
Yes.
to your history, the 4 years recent increase in size and of late it is getting pain. So I have to keep the possibilities at. So I'm thinking of benign tumor, but however, I would like to rule out the possibility of a malignancy in this case because the symptoms suggest to a rapid increase in size and as well as the pain, onset of pain. It's a
Yes.
unilateral swelling. Unilateral swelling.
Okay. So have you got a slide of summary of history?
No, sir.
Acha, you have not. keep one that summary of history, right?
Yes, sir.
In a
So,
shorter
Vivek,
form.
Dr. Vivek, just one question from my end. What are the risk factors for parotid tumor?
Female sex is a risk factor. Caucasian group,
Is that female sex, Caucasians? What is the most important factor here? What is the common
smoking,
age for, say, parotid tumors?
late 40s to 50s, sir.
No, it's 60s. 64 is in
60,
fact
60.
median age. Okay.
Median age.
What else? What are the other risk factors?
Smoking
You
is a
have to
risk
ask
factor.
for those risk. You have to ask for the risk factors in your history.
Yes, sir. History of radiation exposure is a risk factor, sir.
Okay. What else?
History of smoking, sir.
Yes, very good. So these are the ones, right?
Similarly, you have asked no history of malignancies in family. What does it mean? Why you have taken that specific history? Which malignancy will have a bearing on your? I think he left. He left, I think.
Which parotid malignancy is responsible? That's what you wanted to?
No, he's gone. He's gone.
Okay, we lost his connection. Okay.
Right.
Sir, I can hear you, sir.
Oh,
yeah, he's come back.
okay. Back. Okay. Okay, great. Okay. So did you understand? You said no history of malignancy in family.
Yes.
It's a very general statement you have used.
Actually, which malignancies are you looking for?
If they contribute for the parotid swelling, other words.
Yes.
Squamous cell carcinomas can run in the family, sir.
Parotid squamous cell carcinoma?
Less likely, sir.
So there is no malignancy.
More important. There's something more important. Something to do with lymph nodes.
Yes, sir. Lymphomas, sir.
Yes. Lymphomas can run in the family. This could be jolly well be a lymphoma of the parotid.
Right.
Yes.
Very good.
Okay. Yeah.
Okay. So what I wanted to say is this is a very general term you have statement you have used. And all family member in all family there will be history of some malignancy. Do you understand?
Yes.
It's a very difficult that no history of malignancy is a very general term. I would not like to use that statement at this level. Okay.
Yes.
So you are thinking only of either pleomorphic adenoma or similar tumor. What are the other swelling which can occur in parotid? Apart from, we have thought of this all neoplastic tumor, we have also thought of the degenerative in form of Sjogren and those infective. Which other? Which are so rare can be there.
Non-epithelial tumors are possible, sir. Like
I have said, understand the question. I have said no neoplastic. Forget about neoplastic, I am saying. All I agreed, even lymphoma and everything is neoplastic.
It could be inflammatory or autoimmune. Either of these two have to think of.
Anything else?
Parotid abscess is a possibility, sir, but less likely in this 10-year history.
Very good. Can you think of any other swelling which usually occurs in younger patients, but they are seen in parotid, and you have to be careful about that. One is a hemangioma, though occurs in a very young patient, AV malformation, and one more is a lymphangioma. Never forget that lymphangioma do occur in parotid, and they can be there for a very long time without increasing in size or remaining static. But yes, I agree your point that it will occur in a very comparatively younger patient, but keep that thing in mind.
Could there be a metastatic tumor in a parotid?
Yes, sir, it is possible because parotid is also a lymphatic tissue.
Okay. From which primary they likely to have a metastatic deposits in the parotid?
From the scalp and oral cavities.
The scalp and oral cavity. Okay.
Sir, just I would like to see, have you got that photograph before we move on to examination?
Yes.
Yes, sir.
Just show it. Lateral view. Okay, fine. Though you have described according to patient, it is in front, below and behind. Does it look like that?
It is less behind.
Behind.
Is it below? There's no behind the ear lobe, it is below the ear lobe and front of the ear lobe, partly.
Yes.
Because I had seen that photo, that's why I asked. So be
Yes.
careful. What the patient say, describe according to what you are seeing actually. There is nothing behind the ear. You are describing according to book that it will be the parotid swelling should be like that. But it is not always like this. This swelling is nowhere behind the ear, what you are saying. Anyway, in examination, we will have a look at. Thank you.
Go for examinations now.
Yes. General physical examination of the patient.
Yes.
Patient was examined in a well-lit room after taking verbal consent with exposure of head and neck region. Patient is conscious, coherent, and well-oriented to person, place, and time. Patient is moderately built and well-nourished. There is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Vital data of the patient is normal. Patient is afebrile. Pulse is 80 beats per minute in the right radial artery. Regular in rhythm, normal in volume and character. There is no vessel wall thickening, no radioradial or radiofemoral delays. Blood pressure is 130 by 80 millimeters of mercury in the right arm in sitting position. Respiratory rate is 16 cycles per minute, which is abdominothoracic in type. Local examination of the face. Inspection, a single swelling of size 5 into 5 centimeters with well-defined borders located below, in front, and behind the right ear lobule, extending superiorly till the tragus, inferiorly angle of mandible, medially till halfway between the angle of mandible and the chin, posteriorly till 1 centimeter in front of the mastoid process. Swelling is obliterating the retromandibular groove and lifting the right ear lobule. Surface of the swelling appears smooth. Skin over the swelling appears normal without any erythema, ulcers, scars, fistulae, or dilated veins. Swelling becomes more prominent on clenching teeth and less prominent on opening the mouth. There is no difficulty in closing eyes, no loss of nasolabial fold. There is no difficulty in blowing or deviation of angle of mouth, and no drooling of saliva. No other swellings in the head and neck region. On palpation, there is no local rise of temperature over the
Vivek,
swelling.
wait, in inspection, you told lifting of earlobes, no? I think
Yes,
there is no lifting of earlobes. In the lateral view also. Okay? Sir?
Yes.
Sir, others' opinion.
Yes,
Yes.
there is no fullness behind the ear lobule.
Yes.
So there is no obliteration of the retromandibular groove.
Mandibular.
The swelling is
Yes.
situated below and in front of the angle of the mandible,
Yes.
partly towards the in front of the tragus.
Yes.
Yes. Yes.
Go
Yeah,
ahead.
go on, Dr. Vivek, go on.
Inspectory findings of the swelling site, size, and extent were confirmed. Swelling has smooth surface and variable consistency. The swelling is mobile. Skin over the swelling is pinchable. There are no swellings in the opposite left parotid region. No other swellings in the head and neck region. On oral cavity examination, mouth opening is adequate.
Wait. The skin over the swelling is pinchable. What it means?
Ma'am, can we let him finish the examination? Then we'll ask him the questions.
Okay.
Sure.
On oral cavity examination, mouth opening is adequate with the good oral hygiene. There are no ulcers, swellings, or discharge. No erythema or discharge at the opening of right Stenson's duct. There is no fullness of tonsillar fossa. Parotid duct is palpable and deep lobe is not palpable on bidigital examination. Systemic examination is normal. Cardiovascular system, first and second heart sounds were heard with no murmurs. Respiratory system, there is bilateral normal vesicular breath sounds with no added sounds. Central nervous system, no focal neurological deficits. Abdomen examination, abdomen is soft, non-distended with no palpable masses. My provisional diagnosis for this patient is right-sided mixed parotid tumor, likely pleomorphic adenoma.
Coming to palpation, no? Put the palpation slide. You told it's a smooth surface and variable consistency. What does it mean? Whether it's a firm in consistency or some places it's soft.
It has areas of firmness and softness in between.
So indicates what?
It has pleomorphic origin.
Whether it should be uniformly.
Pleomorphic has got very variable consistency.
Yes, sir.
Why?
It arises from both epithelial and mesenchymal components.
So?
Epithelial components are firm and mesenchymal components are soft in consistency.
No. What mesenchymal components?
That's
not at all.
Yes, sir.
What mesenchymal components make it soft?
That is
Myxoid stroma is present.
Vivek, that is a histological component. So they never present clinically like that.
Clinical, yes.
Yeah.
Got it? No, they don't present like clinically. It is what you said. It is a histological component.
Yes.
Don't
So
correlate
they
histology with
histology.
clinical findings. Okay.
So it is pleomorphic adenoma never presents as a mixed consistency.
Mixed
So it is a uniform firm to hard inconsistency. You could say that.
Yes. If it is hard, it's a malignant.
Malignancy.
Go ahead.
Dr. Brindavan, have you
Next.
examined the deep lobe? Can you comment
Yes,
on the
sir.
deep lobe?
On oral cavity examination, deep lobe is not palpable on bidigital examinations.
No, hang on. You put your finger inside his mouth to palpate the deep lobe, do you?
So it's not
Yes.
called bidigital. It's called bimanual. And in inspection only, it's better to see the deep lobe.
Yeah, you call inspection, you can find out whether the deep lobe is involved or not.
Yes.
Okay, let's go to your first slide of examination, general examination. I hate this kind of thing, radio femoral delay and all. Do you do that? No. Next slide.
Next one.
Wall thickening. No, go back.
That's the slide. Previous
Previous slide.
Yeah. Radio femoral delay. Okay. Why? In which conditions will you get this radial and radio femoral delay?
Radial delay is seen in coarctation of aorta, postductal
So
coarctation.
what are the features of coarctation of aorta? What will the patient complain of in coarctation of aorta?
See, this is unnecessarily inviting the problems because they were nowhere related to the parotid swellings or neck swelling in that matter. You could just
Vivek,
pulse rate. That is important. That's the only thing.
Vivek,
Don't add on things.
In your exam, just tell us what you do in the wards.
Yes.
That's true.
That is the best that you're always doing right in the ward. You're not. Have you ever in your ward taken radiofemoral delay?
No, sir.
Entire your clinical period, forget about not this swelling. Nobody will do this.
Never in your life, yeah. I've not done it in my life.
Even I have not.
Okay.
I believe
Just
that
your
it
first
is
slide.
important if there is some
Total
associated
radiofemoral
metabolic
delay
condition.
we can see in the thyroid cases. If it is due to atrial fibrillation, some emboli will go.
Thyrotoxicosis or something like that, then yes.
There we can say.
Otherwise, don't
No
go
need.
put your
Yes.
book in like that. The sir is very
Similarly,
right.
Vessel
Means,
wall thickening.
why do we do all this? Radial and that. You have any answer? Why do you do it? Will it help you diagnose the parotid malignant or
No,
benign?
sir. Not related.
Understand this point. So just
Vivek,
try to
you
skip
don't
it.
gain points, you lose marks.
Yeah.
Yes.
Right.
Okay, let's see our general examination. Slide before that. Pallor rectus, sinus clubbing, generalized lymphadenopathy, pedal edema. Okay. So what do you mean by generalized lymphadenopathy?
Involvement of more than 2 non-contiguous groups of lymph nodes.
Good. Okay. Next slide. Next.
Next one.
Okay. In your palpation, sorry, this is
Right.
fine. In your palpation, I say this is a lymph node. This is not a parotid swelling. Can you refute me?
Lymph nodal
What is the
swellings
test?
can
Yeah.
ability to move the swelling above the level of zygomatic arch is possible in lymph
Have you
node,
done
but
that?
not.
Have you done that?
Yes, sir.
Where? Where? Palpation. Let's see. Get next slide of palpation. Where? Not done. Okay.
Not mentioned.
Also, fixity to the skin is not by pinching. If the skin is fixed to one point of the tumor, you can pinch it on the other side. So the better way is that if you move the tumor, and does the skin move along with it?
Yes, sir.
Okay.
What's the curtain sign?
Vivek, you have written that swelling is mobile. What do you mean by that?
Yes.
Up, down, superior, laterally.
Swelling is it is mobile. We can move it in both horizontal and vertical directions, sir, but we cannot be moved above the zygomatic arch.
In your case, it moves in both directions.
Is it fixed to the masseter?
No, sir, it is not fixed, sir.
How do you know?
On contraction of masseter muscle, if there is restriction of movement along the
You've not
direction.
written it here. You've not written it.
Yes, sir.
Dr. Brindavan, regarding the mobility, what's the curtain sign?
Yeah, what is curtain sign?
Regarding the mobility.
Investing layer of deep cervical fascia.
No. What is
What is
curtain
curtain
sign?
sign?
It was the curtain. No pathogenesis in that.
Don't go in
Parotid swellings
anatomy.
cannot
What
be
is
moved
curtain?
above the level of zygomatic arch.
Yeah. Why so? Then you answer that investing layer, this, that.
Yes.
You understand? Don't jump the gun.
Yes.
You should
So
answer when it is asked.
Yes.
Does in
So the
does in
important-
any case the parotid can be still above the curtains line?
In malignancies,
Yes, in
in
malignancy,
malignant cases which breach the parotid
which
space.
breaks the capsule, which breaks the deep fascia, which is the deep fascia, there is no limit for that, it can extend. Similarly holds true for thyroid also. Thyroid will never go above the thyroid cartilage. If it pierces the deep fascia or petechial fascia, then definitely there is no limit for that, it can extend above that. Even in parotid, it remains the same.
Right.
What's the importance of the stylomastoid ligament? What is it separate?
Stylomandibular ligament separates the parotid gland from the submandibular glands.
So how can you
differentiate
that?
Sir?
What is dumbbell tumor?
Involvement of both superficial and deep lobes of the parotid gland.
No, it's not related just to parotid. It can be related to even any lymph nodes. Okay.
Yes, sir.
How you differentiate the parotid tumor from the parotid group of lymph nodes? Let's say it is a lymph node.
Lymph nodes are superficial to deep fascia, sir. On parotid swellings become less prominent on wide opening of mouth, while lymph nodal swellings do not become less prominent on opening.
They're not become less prominent, they're still mobile, probably. Whereas the parotid restricts the mobility and it becomes less prominent. How to check the
What about clenching of teeth? Or just opening of mouth. Suppose I open the mouth. What about clenching of teeth? How do you know this is not fixed to the masseter?
On clenching of teeth, masseter muscle is contracted, and if
Right, so
parotid
all
is
this has
fixed
to
to the
come. Dr. Vivek, all this these are important things. Much more important than radiofemoral delay. This has to be written there. Do you get me?
Yes, sir.
So your curtain sign, your fixity to the masseter, fixity to the skin, fixity to the bone, all that has to come out.
Yes, sir.
Right? Yeah.
Vivek,
sir.
The point here is what is the relation of masseter muscle with parotid?
Masseter is related to the anteromedial surface of the parotid glands.
So how the parotid will be affected when you contract the masseter muscle?
If there is a tumor
have you seen the
involved
surgery of parotid?
Yes, sir.
So what is the relation of their masseter and parotid?
Masseter is anteromedial to the parotid glands.
Right, agreed. So what will be affected first if the parotid becomes malignant? Will it fix to masseter or something else?
Facial nerve is first affected, sir.
Facial nerve is first affected when it comes out from the parotid and goes over the masseter. So involvement of masseter is very late many a time. So when will you do the clinching test? What you said, that contraction of masseter muscle, apart from relation of parotid, is there any other role of contracting the masseter?
For palpating the parotid duct stents.
Very good. So have you done that?
Yes, sir.
You have written somewhere the duct is palpated, something like that.
Yes, sir.
Have you written that? I think I read it.
No, he didn't.
Yes, sir. Last line.
Last side. So, is it a common phenomena to have a palpable parotid duct?
Yes, sir. Parotid duct is
Common.
normally palpable, sir.
Normally palpable. In this patient, do you expect that it will be palpable?
Yes, sir.
At which level did you palpate the parotid?
Sir?
At what level? At what level?
What level?
Nearer the orifice or nearer the parotid gland or in between?
Over the masseter muscles. Just
over
below
there,
the 2
but where
centimeter
whole
below the
masseter is
zygomatic.
very large, right from here to here.
The surface marking of parotid duct is, we have 2 imaginary lines, sir.
Yeah.
Okay. One imaginary line joining the ala of the nose to the angle of mouth. And another
don't go
imaginary
and teach
line.
much of detail, common sense.
1/3 of the imaginary line joining the tragus to this imaginary line. Middle 1/3.
Okay. Anyway, what about the parotid duct opening inside?
It opens opposite the crown
No,
of
not theory,
upper-
practical.
Inspectioning. You
Have you
mentioned
done
about
it?
the parotid opening.
Yes, sir.
So where is it written?
Fourth line, sir, in oral cavity.
What does it say?
The opening does not have any discharge, sir.
So normal salivary discharge is also not coming.
I meant there is no pus discharge, sir.
Yeah.
So
Under
when will you get the pus discharge? We have already gone through this. So
No,
only thing you look for a discharge or anything else which is important?
Is the inspection is sufficient to look for the opening, or does you need to require any palpation also? If so,
Palpation
why?
is also.
Why you need to palpate? I'm not talking about the duct. I'm talking about the orifice. If pus is not seen, if the saliva is not seen, what else you could see in case of the duct is involved? If the malignancy is extending all along the duct, no, you could see the induration, you could see the ulceration, you could see the bloody discharge from the orifice. All the things can be possible if the malignant process is extending all along the duct.
Yes.
Okay. Seropurulent discharge is the inflammatory. Is a bloody discharge with the induration or impacted stone at the orifice. All this, so duct orifice also opening need to be inspected and as well as palpated.
And
Yes,
even you can see the stone sometimes.
Sometimes it's protruding.
You can see the fibrosis, particularly if the nearby tooth is involved. Fibrosis can also be the Hood sign, sometimes it is known as, which can also be seen. So parotid duct opening examination is important. That's why I asked where does it actually open.
Yes.
Okay, go back. Show me the photo.
Which muscle does the parotid duct penetrate?
Sir?
Photograph.
Dr. Bindavan, which muscle does the parotid duct penetrate?
Buccinator muscle, sir.
Okay. So if you have said anthem, if you have to describe this swelling, where is the most prominent swelling in this photo?
At the angle of the mandible, sir.
So why do you say it is parotid? So have you examined submandibular duct or no?
Yes, sir.
You have examined?
Yes, sir.
So I don't think you're written. Anyway, so keep that thing also in mind, though in most of the time you will get the mixed parotid tumor and that side. But always here, does it look like a parotid?
If so, in what part of the parotid having a tumor in this case?
Yes, that's what actually I was going for. Yes.
Tail
So
of the
if it is parotid, which part it is?
Tail of the parotid, sir.
Tail of the. Which tumors are common in tail of parotid?
Warthin's tumors.
Warthin's tumor. So, at which age Warthin tumors are common?
Young males, sir, around 30s.
Okay. 30 to 40, around.
Yeah, right.
Are they malignant potential? Are they have malignant potential?
Warthin's does not have malignant potential.
Yeah. What is another name for Warthin's?
Adenolymphoma, sir.
Adenolymphoma. So it's predominantly lymphatic structures, involvement of that. It can be bilateral, it can be soft, occurs in middle age around 40, doesn't have a tendency to go for malignancy. These are the few descriptions of the Warthin's tumor.
Vivek,
How will you diagnose?
read your first two lines. Does it of matching or simply because it is parotid you have to write down that? What does it say?
It is obliterating the retromandibular groove and is lifting the right ear
That is
lobule.
wrong.
So does it lift the right ear?
In your case, no?
It is front and below to the lower part of the pinna, only that area.
Yes, sir.
It is not lifting the lobule. You have seen it, not. Second point is when you say skin over the swelling is normal, right?
Yes.
So why you need to say write down all these things?
Yes, sir.
Because some examiner will ask you, so when will you find erythema?
In sialadenitis and parotid abscess is possible.
Parotid abscess and sialadenitis, inflammatory commonly.
Yes.
Does malignancy have erythema?
No, sir.
Yes. No?
Why? Why?
You're not seen in the breast so many times?
It can. It can.
It can involve.
So the best thing is if it is present, mention it. If it is not present, normal is sufficient.
Yes, sir.
Same thing, because you are giving the chance, like examiner like me would like to pull your leg. So what are multiple fistula or one fistula? You have said fistulae. That means it is plural. This is, I agree, it is not pertinent, but remember this point. So how,
Yes, sir.
if there are multiple fistula, what does it mean? I have
Salivary
rarely seen that. Solitary fistula usually associated with surgery, mostly. Which surgery will cause the parotid fistula? Common surgery that will cause parotid fistula.
Superficial parotidectomy.
Parotidectomy.
No,
Yes.
No,
no.
commonly
If it done properly, superficial parotidectomy shouldn't have a.
It should not cause. Is there any lesser form of surgery which you do more often? Sometimes.
the patient will come with parotid.
Extracapsular dissection.
No.
Yeah.
So, if it is parotid abscess with incision drainage itself, will
IND
cause
is the
parotid.
commonest. Drainage of
Okay,
parotid
incision
abscess lead to fistula. That is the
parotid
one
fistula.
common. And inadequate excision. If you have not gone for superficial parotidectomy and you have done only excision biopsy or like that, those patients can end up with the parotid fistula. So point here is that if you write down anything, you should know the answer.
Yes, sir.
You understand? So do not, once the skin is normal, let the examiner ask you. If you had not written anything, I would not know I should ask something about parotid.
Vivek, in inspection itself, he told the skin is normal. No need of telling in the palpation. He told in inspection, the skin over the swelling is normal. That is enough.
How different is the parotid abscess from other abscesses? Is there any peculiarity?
In parotid abscess, we do not wait for fluctuation to develop. So,
Why?
because there is potential for the abscess to grow before
What?
it.
No,
What
no.
is true capsule? What is false capsule?
What anatomical factor is responsible for this? Try to say that you are not supposed to wait till the fluctuation to develop. What prevents the fluctuation to develop?
That is a very simple answer, and you should know that answer.
Yes.
You were telling something about
The
attached to
parotid
the zygoma that
parotid fascia is not tightly adherent to the gland.
not or yes.
Not tightly.
Is parotid fascia is preventing the fluctuation to be elicited. Sir.
Very stout parotid fascia fixed on all sides prevent the pus to come out. So there will be a swelling will be minimum, pain will be maximum. You should keep that thing in mind. Okay, sir, please. Should we go
Okay,
further?
Vivek. Okay, Vivek, one question from me. Which are the other areas where you don't wait for fluctuation to happen?
Yes.
Let's have that.
Perianal abscess, sir, breast abscess. Sir.
Then,
Anything else? Scrotal abscess.
Yes.
Why don't we wait for breast abscess for fluctuation or perianal abscess? Or even for parotid, why don't we wait?
There is potential space for the abscess to grow till it develops fluctuations. So only in late phases we see fluctuation.
Okay, so they'll be delayed. But what about parotid? There may be pain. What else can happen? There can be pressure necrosis of the facial, can involve the facial nerve because of increased pressure. Okay.
Patient can present with a facial nerve palsy, then excruciating pain because it produces compartment syndrome. It is a thicker fascia with a closed compartment space. Where little swelling, inflammation of the gland many times brings the patient to the casualty for severe pain. Okay, so don't wait for the fluctuations. So you have to drain it early. What are the incisions you would like to put it if it is a parotid abscess? Where you would like to place?
Blair's incision is preferred, sir.
Pardon?
Blair's incision, which is a vertical skin incision in front of the ear, whereas the parotid capsule is incised horizontally along the fibers of the facial nerve.
Very good. So that avoid the facial nerve because your incision has to be parallel to the facial nerve. Skin incision is vertical anterior to the tragus. This is the different from other abscesses. This okay. Okay, sir. Next point.
Vivek.
Which structure passes between the superficial and deep lobe of the parotid gland?
Fasciovenous plane of Patty, sir,
Okay.
which includes the facial nerve, retromandibular vein, and the axial carotid arteries.
Which
Wait,
will
did
be
you describe
superficial?
How do you
the
localize?
facial nerve here?
Which will be
Sir?
superficial in the order to tell.
Facial nerve is the superficial most, followed by retromandibular vein, and next is
Vein
the
and
artery.
then artery. Yes. Okay.
Vivek, did you tell about the facial nerve involvement in this patient?
Yes, sir.
Have you written somewhere about the
Yes.
facial?
Where is it?
Examine
Show it. Show it. Where is it?
No
This
difficulty
first
in
line, sir.
recognize no class of fish.
In an examination.
Yes, sir.
Inspection will return. Okay.
In inspection or in palpation or in both?
In inspection, sir.
Only in inspection. You have not done it in palpation.
How do you check for the eyes?
Forceful closure of
Closes the
eyes.
eyes. How do you check for that? Only on
Forceful closure of eyes against
That is
rest.
enough. You ask the patient to lift the eyebrows, no?
Yes, sir.
For the frontal is missing.
Yes,
And
sir.
on inspection, there are multiple scar marks on the face. Did you notice that?
Yes, sir.
And you have not described anything about that? What are
He has,
those?
he has said no scar mark.
No, but there are multiple scar marks.
Yes, sir.
So many
Acne
scar marks are there.
scars.
So what is that?
Acne, sir.
Huh? Acne.
Oh.
So you should have described.
Doctor,
There are so many abnormal scar marks are there. Can this patient have developed the chicken pox or the mumps sometimes? And now he's having the scars there. And that mumps is causing this parotid swelling.
Recurrent. Does it cause?
Recurrent silidinitis is a possibility in mumps.
In your
Recurrent mumps
case,
infection.
is it unilateral or bilateral?
Unilateral. No?
Yes. In a mumps, it will be bilateral. Okay.
Okay.
So,
Vivek, how do you localize the parotid facial nerve trunk?
Intraoperatively, sir, there are
Intraoperatively.
specific landmarks, namely Conley's point, tragal point, sir. Tragal point, the nerve trunk lies 1 centimeter below and deep the tragal cartilage, and 1 centimeter below and deep the osteocartilaginous junction of the ear, and just deep the posterior belly of digastric muscle. And retrograde method of tracing the nerve through the from the branches of the facial nerve.
Okay, how do you investigate? We'll go for the investigations.
Okay. Let us say, what is your diagnosis?
Yes.
Now, examiner, just tell me the diagnosis.
Right-sided mixed parotid tumor, likely pleomorphic adenoma, sir.
Why we call it mixed parotid tumor? So mixed parotid tumor and pleomorphic adenoma are different?
Pleomorphic adenoma is mixed parotid tumor, sir.
So you said mixed parotid most probably due to pleomorphic adenoma means? Okay, why do you say it is clinically, why do you say it is pleomorphic adenoma?
Because it has a variable consistency, sir.
first
And
you
most
have to
common
tell the
parotid tumor
site.
is pleomorphic adenoma.
Vivek, first tell the site, then inspect findings and palpatory findings. Don't
It
take
is
the
a
palpatory
swelling.
finding first.
It is a swelling in the parotid region of the face.
Yes.
Having variable consistency.
Don't tell variable consistency. Already they showed. Huh?
Dr. Vivek, don't
Sir.
give us a pathological diagnosis. It may be the most common thing, but
Yes,
that doesn't mean it is the thing, right? So just say that it's a parotid tumor, likely to be benign.
Benign.
Yes.
Yeah, that's it. Of which side? Right side. Okay, right-sided parotid tumor. Okay.
Yes,
So you don't opt for any differential diagnosis. Only one diagnosis.
If still examines persisting for what could be the probability, then you can answer that.
Yes, sir.
Okay, how do you investigate this patient?
I would like to subject the patient to ultrasonography of the right parotid region, sir.
Okay. What are the areas of your concern where you would like to see?
I want to look for the organ of origin from which the swelling is arising.
Does ultrasound tell you that is organ of origin? Does it rules out the parotid?
It says that there is a lesion in the parotid gland, sir.
Only that can make out. You cannot rule out it is not a parotid. It is a parotid. Okay, unless
Yes.
you go for other investigations. What other morphological features do you expect? Because you have made a clinical diagnosis of benign parotid tumor, most probably a
Yes.
pleomorphic adenoma. On that basis, what are the findings you are expecting on ultrasonography?
It is likely hypoechoic lesion with internal echoes with well-defined margins in the superficial lobe of the parotid gland.
Internal echoes. What do you mean the internal echoes?
There are calcifications in parotid pleomorphic adenoma, sir, on ultrasound.
Okay.
Involvement of deep lobe can be seen. Will
Does
be ruled out.
ultrasound will
In
tell you?
ultrasound, can you see the deep lobe? What is the indication of CT in a parotid?
If there is suspicion of deep lobe involvement or malignancy,
that's
it is
what.
an indication for CT.
CT. Then ultrasound, how can you detect the deep lobe?
Are they anatomical lobes, true lobes or false lobes?
They are not anatomically
Okay.
well different.
It is only lymphovenous plane which descriptive purposes we divides. Superficial to that we call it superficial lobe and deep to the deep lobe. So ultrasound will no way differentiate from that. Okay.
Yes.
Even if only CT can make out the deep lobe involvement is there, or clinical examination if there is any bulge in the nostril or fossa, you can suspect that and you can biodistally palpate that also. So ultrasound will never tell. So it will not tell the superficial lobe or deep lobe. They could say only a mixed lesions or a hypoechoic lesion in the parotid gland.
Yes.
Unless the entire gland is enlarged, so they have different features for that.
Yes.
Then could you expect a solid and cystic component in that if you're suspecting the pleomorphic adenoma?
Yes, sir.
Cystic component would you expect?
Cystic it looks hypoechoic because of myxoid stroma, sir.
So you are generally don't.
Component on ultrasound.
It mimics, but generally, if you put a needle, you don't aspirate any fluid there. Okay, ecogensity is different from that. Then what else you expect on a sonography?
Lymph node. We can look for enlargement of lymph nodes, sir.
Does it differentiate? Your ultrasound it differentiates lymph nodes from the parotid swelling?
No, sir. Other than this lesion, if there are any enlarged lymph nodes, we will look for in the ultrasound.
So you are not talking about the parotid group of lymph nodes. You're talking about some other group of lymph nodes which drains the parotid?
Yes, sir.
Okay. Okay. What are the other groups of you're interested to know?
Upper deep cervical lymph nodes are commonly affected.
Okay, then? What about in submandibular area?
Submandibular, other salivary glands are examined on ultrasound.
No, submandibular group of lymph nodes, do they involve in parotid swellings?
No, sir. Other salivary glands are examined on ultrasound in submandibular area.
Okay, you should see.
Sir is asking, does it parotid malignancy goes to submandibular lymph node? Forget about saliva.
No, sir.
No.
No.
Why no?
Which are the draining area of the parotid?
Parotid lesions go to intraparotid group of lymph nodes, parotid lymph nodes, and upper deep cervical lymph nodes.
No. Pre-auricular, post-auricular, and then parotid group of lymph nodes, then submandibular group of lymph nodes, and upper deep cervical group of lymph nodes. These are the
go by numbers. Level 1, 2, 3. That would be the better in today's.
Yes.
Right? So do not forget, read about it and find out the drainage of parotid.
Yes, sir.
Right? So after ultrasonography, as sir has other investigation?
Yes, sir. Fine needle aspiration cytology from the lesions.
So would you do in this patient?
Yes, sir.
Why?
Yes, sir.
Why do you want to do it?
To get a cytological diagnosis of the
Obviously,
lesion.
but why?
To rule out malignancy, sir.
Will it rule out?
Vivek, what is Nillen criteria of FNAC for salivary glands?
It is FNAC criteria for salivary gland tumors. It has Milan 1 is non-diagnostic.
What is
Milan 2
4B?
is
Sump
4B.
means what? Sump.
salivary neoplasm of
Uncertain.
uncertain metastatic potential. Malignant
Malignant
potential.
potency. So it's a 4B. What is the chances, percentage of malignancy in 4B? How many percentage it's turned into malignant?
Percentage, I'm not sure.
It is 35%. The chances of malignant will be more. So what is, you have to treat it with conservative. So from 5 and 6 only the surgery will do.
Yes.
Okay,
What is the role of CT in parotid tumors? Would you like to go for a CT for this
Or
patient?
MRI.
Or MRI, either.
So which one will you prefer, CT or MRI?
In this patient, I would not subject the patient to either CT or MRI, sir.
Why?
Because I'm not suspecting deep lobe involvement or skull base involvement or malignancy, sir, or facial nerve involvement.
Okay.
Okay. But
so
suppose
it's
you have to
staging,
do.
what stage it is?
Sir, ma'am?
Staging of parotid tumors in malignancy. You tell the stage, no?
In
If
in
you
TNM
told
stage,
skull base, no? If
yes,
skull base involved, what is the stage?
4B, ma'am.
4B.
Yes.
This 4A?
4A is facial nerve, masseter or
Skin.
skin
Yes.
sternocleidomastoid involved.
Yes. Go ahead.
Do you have any radiological signs to say that the gland is malignancy? Radiological signs. Suppose if you have done MRI or CT.
Yes, sir. There will be loss of facial planes around the swelling and perineural invasion of the.
Oh, that perineal invasion is histological diagnosis or
In the
radiological
CT, we can
diagnosis?
see, perineural invasion.
Only on MRI it can be seen.
MRI.
Okay.
MRI also not different, not to mention that lymphovascular
Very
invasions.
difficult.
No, they may say the tissue planes are obliterated. That's all they can make out. It's the best investigation for the soft tissue modalities. Then radiological means if there is very bony deformity, which are seen on a CT or an MRI, particularly
like the
which nerve comes through which foramina?
facial nerve comes through stylomastoid foramen.
What will be the normal size of the stylomastoid foramina? Generally equal to the size of the nerve. If it is if it is the extension of the tumor all along the nerve, in the long-standing cases, it can widen the stylomastoid foramina. That can be better seen with an MRI rather than on a CT.
So nowadays people prefer MRI.
MRI.
Particularly when you are suspecting malignancy, it is a definite.
Definitely.
One more point, you said that you are not suspecting malignancy. I would say it is an overstatement. Do you understand? Sir has said initially patient has come after 10 years. So there may be a chance of conversion to malignancy, which patient may or may not tell you about pain or anything. So we do suspect malignancy, and in exam, I would advise you that you say MRI or CT. Whatever. At least in this particular case, you must say. Don't take it for that you are saying it is not malignancy means it is not malignancy. So what will be the evidence of malignancy in MRI?
It will be indefined. It will have indefined margins.
Okay.
Okay.
Loss of facial planes around the lesion.
Yes.
And involvement of surrounding structures. Extra parenchymal extension.
Extra parotid. Contiguous structures involvement.
Yes, sir.
Okay, Vivek, clinically, what are all the points to say the parotid is malignant?
Gradually progressive swelling, turning
Sudden
rapidly
increase in
progressive.
size. Yes, good.
Sudden
One.
increase in size.
Yes.
Painless swelling, turning
Pain. Yes, good. Then.
Involvement of facial nerve.
Yes. Then consistency.
Firm or variable to hard in consistency.
Hard in consistency.
You always variable, hard in consistency.
Yes.
Then.
Involvement of skin and lymph nodes.
Then
and loss of
temporomandibular joint, no? Temporal mandibular joint. The movement will be restricted.
Movement
Why?
will be restricted. Okay.
In the history you have mentioned no difficulty in opening the mouth. You have mentioned in the history?
Yes.
Okay. Okay. So there is no trismus.
Okay.
Yes, sir.
Okay.
Okay, so you have done all in everything is suggested is a benign tumor, most probably pleomorphic adenome,
Yes, sir.
right? Why it is known as a pleomorphic adenome?
It arises from multiple components, histological components, sir.
Mhm.
Both mesenchymal, epithelial, and myxoid stroma.
Right. I think we have already, sorry. Okay, why you need to do, if it is a benign mixed parotid tumor, why you need to do superficial parotidectomy?
Because we don't want to damage the facial nerves, sir.
No. If you do excision, it will be fine.
Oh, because pleomorphic adenoma is known to have extracapsular extensions in the form of pseudopods.
Right. So capsule
Recurrence
is
is-
having pseudopods. So there is no well-defined capsule and chances of leaving behind is there. Suppose it is benign, you leave behind some part. What is wrong? What will happen?
Recurrence of pleomorphic adenoma.
Anything else apart from
Anything-
recurrence?
Immediate post-operative period.
Okay. So a recurrence, if it occurs, likely to be malignant.
Yes, sir.
So that is why it is very important that you do. So what are you planning to do in this patient?
Right-sided superficial parotidectomy under general anesthesia.
Under general anesthesia.
What incision you'll put, no?
Yes. What incision you will
Okay,
do? Yes.
okay. Just a second, sir.
Please.
Suppose the patient says he doesn't want any surgery. It's a 4 centimeter small tumor,
Yes, sir.
doesn't want surgery. What do you tell him?
80% of pleomorphic adenomas remain benign even if not operated.
So he says, fine, 80% doesn't, no problems. I'm going back home, tata, bye-bye.
There is
What will you
potential for malignant conversions.
So there's a risk for turning into
Malignant.
malignancy.
10 years, no
Also,
long
anything
standing.
else?
They can.
Yes.
Anything else? More important, malignancy is uncommon. Anything else which will convince him to get it operated? It'll increase in size. It's 4 centimeters now. After a couple of years, it'll be 8 centimeters.
Yes, sir.
Right? Yeah. Okay, now describe the incision.
It is a modified Blair's incision or laziest incision is given, ma'am.
What is the
Why
position
do
of
you
the
give a
patient when you are
lazy
doing the
incision?
superficial parotidectomy?
Position.
Sir, sorry, sir.
What is the position of the
Position of
patient?
the patient. Patient position.
Patient is supine position with the head tilted to the opposite side, sir.
Mm-hmm. And
Most important.
Anti-Trendelenburg tilt is given for 10 to 15 degrees
you mean the head
Why?
down?
to empty the veins. Prevent
Head
venous
low?
congestion.
Head low or head up?
Head up, sir.
Head up. Why?
To empty the superficial veins to prevent venous engorgement.
Venous congestion during surgery. Okay.
Hmm. How will you drape the patient? How will you drape the patient?
Very particular question sir is asking. Is it different from other when you drape the inguinal hernia, when you drape the parotid tumor? Is there any difference?
There's a particular name for that. What is that technique called as?
Not sure,
It's the
sir.
Hopsley technique. And the most important thing the Hopsley technique is, what are the most important things when you're doing the draping? Apart from the exposure of the area, what else you have to expose?
The face.
Face what?
I'm not sure of this draping technique.
Why face you need to expose during surgery?
While dissection, if there is any electrocautery, if it involves the facial nerve, there is twitching of the facial muscles. We need to look for that.
Keep on watching.
Collateral damage from
If you are using the nerve stimulators to protect the nerve fibers, no?
Yes.
So that will safeguard you. Oh, that will give indication that twitching of the muscles indicate that you are nearer to the nerve, that you can take the precautions and you can do it. Anything else?
Precautions in incisions.
No, draping. Sir is asking draping.
Draping.
You have to look at the eyes. You have to look at the angle of the mouth. No, you have to look that.
Two muscles, no? Orbicularis ovaris and orbicularis
Yes.
oculi.
Okay.
Then you have to keep your gas piece in the ear to protect your spillages going there. Then you have to take a bite at the ear lobule just
Yes.
for the elevation purposes. Okay. These are the precautions you have to take while doing
During
draping.
the nerve monitoring also, you put the electrodes mainly in the orbicularis oculi and ovaries. Two
Okay.
sides. Okay. Yes. Good.
So plan your incision now.
Which incision did you say?
Laziest modified Blair's incision, sir.
Which was the original incision?
Blair's incision, sir.
Before
Only
that, cyst trunk incision. Like a cyst trunk operation for thyroid, the cyst trunk incision. So what is difference? What difference we are making?
in modified Blair's incision, we make sure there are no acute angles, sir. At
Very
the
good. That's the most important. That's why the other better word is lazy S incision.
Yes, sir.
Right? So what should be the extent of incision?
The incision starts at the hairline in front of the tragus, descends below and encircles the ear lobule.
Why
and
does it
extends
encircle the ear lobule?
To look for the facial nerve, sir. Trunk of the facial nerve.
Two reasons.
We need exposure.
Two reasons. One is the one sleeve of parotid goes behind, which is to be taken care of. It should be elevated. And identification of facial nerve, we have to have exposure of mastoid. Right.
Yes, sir.
And anteriorly, and then lower down?
The incision extends till the tip of the mastoid and extends down, bisecting the space between the sternocleidomastoid and the mandibles.
No, skin incision up to which level, and how will you put the lower part of skin incision? So it should not go beyond the angle of mandible. It should be, and minimum 2.5 centimeter below it.
Yes.
To prevent the accidental injury to when the lowermost nerve becomes superficial, branch of facial. Yes. Right? Okay. Up to which level will you extend the anterior flap?
Till not more than the anterior border of the muscles, of the parotid glands.
What do you mean by that?
Flap is not extended beyond the anterior border of the parotid glands. Elevation.
Right. So we already covered that. How will you identify the facial nerve?
Yes, sir. Conley's point, tragal point, deep to the posterior belly of digastric muscle, and retrograde Hamilton-Bailey method of retrograde identification.
Which is the commonest method to use and which is the least method to be used?
Commonest method is in posterior belly of digastric is
or is it posterior belly of digastric or stylomastoid?
Tragal.
Sorry, stylohyoid muscle.
Maybe varies from surgeon to surgeon, I do agree, but still majority prefers. Retrograde, definitely nobody, I don't think anybody will go for retrograde.
Rarely in a recurrent.
There is every chances of injury in the nerve fibers if you go for retrograde. It's never a safe one. Right. Tragal point, you try it. If you don't find it, then you have to search for the posterior belly, the digastric, trace it upwards, probably you may get it. I routinely do the tragal point only, 1 centimeter just in front and deep to that. So 99% you're able to get the nerve fiber, main trunk of the facial nerve. What are the branches?
The facial nerve trunk in the substance of the parotid gland divides into two divisions. The temporofacial and the cervicofacial, which further divide into 5 branches, namely temporal, zygomatic, buccal, that is upper buccal, lower buccal, marginal mandibular, and cervical.
Okay. Among all the other branches, you need the choice. Which branches you are at most cautious? At any cost, you don't want to injure this branch.
Zygomatic branch, sir.
Zygomatic branch. Why?
To retain closure of the eyelids to prevent exposure keratopathy.
Yeah. So angle of the mouth and there are other various procedures are there. The morbidity is less except the cosmetic. But I know exposure keratitis, losing of the eyes is very common. So if it is given choice, you have to be utmost cautious to prevent the branches to the upper eyelid, so as to have a proper closure of the eyelid. Okay.
Yes.
Vivek, you have not done MRI, as you were saying. You have
Yes.
exposed the parotid. You find it is arising from the deep parotid. What will you do? Still, it is benign.
We will plan for conservative total parotidectomy, sir, by retracting the facial nerve and removing both the superficial and deep lobes.
From where will you remove the deep lobe?
By
There are two
retracting the
methods,
facial.
either below the all branches of facial nerve or between two major branches. Depends upon whether they are splayed or not. Okay, you have done a preoperative report is probable malignancy. Now what will you do?
We will perform MRI of the head and neck.
MRI done, probable malignancy.
Yes, sir. Radical parotidectomy is the treatment of choice.
What is that?
Removal of both lobes of the parotid gland and sacrificing the facial nerve and neck dissection, sir.
Which part of neck dissection?
Lateral neck dissection is.
What is that? What is lateral neck dissection?
Neck dissection of level 2, 3 of cervical lymph nodes, sir. Modified radical neck dissection is also preferred.
Sorry.
So reconstruction of facial nerve by using what?
If there is no loss of segment, primary repair of the facial nerve can be done.
Okay.
Using 6-0 polypropylene sutures. If
Yes.
there is loss of segment of the facial nerve graft is done using great auricular nerve.
And or sural nerve.
Sural nerve.
Okay, we can do a reconstruction. What are all the complications of parotidectomy?
I would like to divide the complications into intraoperative, early postoperative, and delayed postoperative. Intraoperative, bleeding is one of the complications, and injury to the facial nerve, and sacrificing the great auricular nerve, injury to great auricular nerve.
Bleeding is common in all surgeries. So
Yes,
this
sir.
is so don't it's not related to parotid. Tell us related to parotid.
Suppose you have to do
What
a
is the dreaded complication?
Trace syndrome.
suppose you have transected the facial nerve. What equipment would you like to have with you for repair?
Sir, I couldn't hear you, so sorry.
Suppose you have transected the facial nerve and you need to repair it. Do a nerve end-to-end anastomosis. So what equipment would you like to have with you at that time?
I didn't get the question, sir.
Suppose you need to repair the facial nerve intraoperatively.
Yes.
So what equipment would you like to have with you?
Loops, sir.
Okay.
For better vision, we need loops.
Okay.
And now monitoring. So you
Yes.
can prevent the facial.
Which forces would you like to have? Dweller's forceps. And which scissors would you like to have?
Not sure.
Ophthalmic scissors, tenotomy scissors, or
Ophthalmics.
Harris scissors, all very fine instrument. Okay.
Okay.
Yes.
And what sort of needle would you like to have on your suture material?
Round body taper point needles, sir.
Actually, it should be cutting spatulated needles, not round body.
Okay, sir.
Because it should be sharp entry, not if you use a round body, you end up fraying the nerve end. Okay.
Yes, sir.
And something else also you require. What else? If you do a nerve end-to-end anastomosis, what else do you require?
Nerve stimulator and electrodes, sir.
Yeah, but you need to wrap the anastomotic site with a collagen wrap.
Yes.
And if you don't have collagen, you can use a nerve vein graft. So to protect the nerve anastomosis. So either you use a collagen wrap or a vein graft to encircle the anastomotic site.
What is mean by Fry syndrome?
It is gustatory sweating, ma'am. When the patient,
It's due to what?
it is due to faulty innervation of
Faulty
postganglionic,
innervation. No.
yes, aberrant innervation of postganglionic parasympathetic nerve fibers of the auriculotemporal nerve to the skin overlying the parotid region, sweat glands of the skin.
Sympathetic fibers from the which salivary node? Okay. So there is
Inferior salivary
parasympathetic
node.
and sympathetic.
Yes,
That's why you are getting sweating, no?
yes, ma'am.
What is the treatment for fries?
Initially, we try conservative management using antiperspirants and anticholinergics.
Okay.
If there is no recovery, we can proceed for avulsion of the auriculotemporal nerve or intratympanic
You can
Jacobson's
inject the
neurectomy.
botulinum toxins. No?
Yes.
How will you avoid fries?
Intraoperatively by keeping the skin flap, thick skin flap with fat,
Yes.
or interposition of temporalis fascia or fascia lata.
Okay.
Dr. Vivek,
Sir,
is there any relation between parotid cancer and breast adenocarcinoma?
not sure, sir.
Both are associated with the inherited mutation of the BRCA1 and BRCA2 genes. And both are having similar morphological similarity and shares various characteristics, including overexpression of the estrogen receptor and female preponderance. These are the relationship between the parotid and adenocarcinoma of the breast.
Yes, sir.
Vivek, how do you grade the facial nerve palsy?
There is House-Brackmann's score, sir.
What is that? What is House-Brackmann?
It considers two components, sir. The ability of elevation of angle of mouth and lateral canthus of the eye. Every 0.25 centimeters is given 1 point with a total of 8 points.
Now, post-operatively, you find a patient is having a facial palsy. How
Yes.
will you proceed with that?
We wait for first 6 weeks considering it is neuropraxia and put the patient on prednisolone, sir. If it does not recover on its own, then we plan for surgical reconstruction of the facial nerve. Before that, we perform lateral tarsorrhaphy to prevent exposure keratitis and tear film to replenish the tear film. We give hydroxymethyl cellulose tear drops for the eyes.
How do you prevent the nerve from going into disuse atrophy? You mean you repair it after 6 months, 1 year.
Yes, sir.
So
Electric stimulation of the nerves.
So you use stents.
Yes, sir.
To stimulate them, right? And you repair by cable graft.
Yes, sir.
Why don't you use a simple graft? Why do you use a cable? What do you mean by cable graft?
In repair of the facial nerve, the opposite facial nerves branches are used, having lower caliber than the trunk of facial nerve. So multiple grafts are used and repaired together to maintain the caliber. So this is called cable grafts.
So use multiple nerve uh, grafts, so that if there's a single nerve, you use at least 3 or 4. So just even a 2 or 3 get joined.
Yes, sir.
Both the sensory and the motor function can be retained.
Yes, sir.
Good.
What is mean by accessory parotid gland?
It is the parotid tissue along the Parotid duct, ma'am. It is also called parotid fascia.
So it's over the masseter muscle.
Yes, ma'am.
Okay.
What are the various complications of the superficial paroidectomy?
I told you.
Intraoperative, early postoperative, and late postoperative complications. Sir, intraoperative is
Operative, I
injury
told,
to
yeah. Tell
yeah,
post-operative.
early postoperative is um, wound infection, flap necrosis, silocele. Late postoperative is salivary fistula and Fraze syndrome.
Usually there are 5 Fs which are there, you know. You know
Yes, sir.
what are those 5 Fs?
Yes, sir. Facial nerve damage, fluid retention,
Yes.
Fraze syndrome, fistula.
Flap
What is
necrosis.
fistula?
Flap necrosis, you know.
Yes.
Flap.
These are the 5 Fs which are there. By that you can remember that. So if there is a fistula is there, what you are going to do for that?
Fistula can be from the gland or from the duct, sir. If it is a fistula from the gland, it will have less output, so we can try conservative management by giving antiperspirants or botulinum toxin and wait for it to reduce secretions on its own. If it is a fistula from the duct, it can be fistula to the outside or to the inside. If it is fistula to the oral cavity, it need not be treated. If it is fistula to the outside, we need to perform surgery, sir. Fistulous tract excision using Newman and Seabrook technique.
Right.
Little points about extracapsular dissection. No? How they will do extracapsular dissection.
Extracapsular dissection is considered in
The
swellings of
incision, the same thing will put.
yes, ma'am. It is
Subcutaneous.
considered in tumors
How will
arising
you
from the
divide the
lower pole.
fascia?
Cruciate incision is given on the fascia.
Yes. Okay. So you have to preserve the facial nerve
Yes.
carefully. So extracapsular dissection avoid the facial injury, facial nerve
Yes.
injury. Then in history also you have to tell about the Sjogren syndrome
Yes, ma'am.
and Mucklix. What is Sjogren's? What is Mucklix?
Mikulicz syndrome is a variant of Sjogren's syndrome, but Sjogren's syndrome is more autoimmune.
What is primary Sjogren's? What is secondary Sjogren's?
Primary Sjogren's involves the salivary and lacrimal glands, while secondary Sjogren's, along with this, it also has connective tissue disorders with
Secondary
joints.
is always along with connective tissue disorders.
Yes.
Okay. Good preparation.
What are the various structures that run through the fascio-venous plane of Petty?
Fasciovenous plane of Patty, from superficial to deep, it includes the facial nerve, retromandibular vein, and external carotid arteries.
Any other structure?
Branch of external carotid artery, namely the transverse facial artery, is also present. Branch of superficial temporal, which is transverse facial artery, runs in the fasciovenous plane also.
Which parotid tuber will spread via nerve sheath?
Adenoid cystic carcinoma has perineural spread, sir.
What is the difference between benign and malignant parotid tumors?
Sir,
Difference between benign and malignant parotid tumors.
clinical history wise, sir.
Okay. Clinically, history wise,
Clinically,
examination wise.
benign tumors are slow growing, gradually progressive, while malignant have a rapid increase in size. Benign tumors are painless, while malignant tumors are painful. Malignant tumors have involvement of the facial nerve. Malignant tumors can have features of extraparenchymal extension like trismus and involvement of temporomandibular joint and masseteric involvement. Presence of lymph nodal swelling is seen in malignant tumors, and skin involvement is also seen in malignant tumors.
What is classification of the parotid tumors?
Parotid tumors are classified into
This is
epithelial and
favorite theory
non-epithelial.
question. This is
Sir?
favorite theory question. This is favorite theory question for PG exam.
Yes.
Classify the parotid tumors.
They are classified into epithelial and non-epithelial tumors. Epithelial tumors are further classified into benign and malignant. Benign tumors most commonly is pleomorphic adenoma. Next is monomorphic adenoma, that is Warthin's tumors, and acinic cell tumor. Malignant epithelial tumors are mucoepidermoid carcinoma, adenoid cystic carcinoma, and carcinoma X pleomorphic adenoma. Non-epithelial tumors are lymphomas, sarcomas, squamous cell carcinomas, and hemangiomas, and secondaries from other
Okay, very good.
Dr. Kanakal, I think we are done.
Yes, Kanakal, sir.
Good evening, sir.
Yes, I think we should conclude now.
Yes, sir. Maybe I will ask Dr. Vivek. Do you have any doubts to be clarified, Dr. Vivek?
No, sir.
Okay. Thank you, Shiv Shankar sir and Subbarao sir, and along with Dr. Sushma ma'am for permitting you to be present here. I thank all the faculty who have joined here, Rahul sir, Pankaj sir, Shanti ma'am, and our own senior colleagues, Dr. Kanna sir and Dr. Rajiv sir, who have been with us for so many years. Roop Jyoti is kind enough to join, and all the other senior professors who have been with us this evening. I thank all of them for being with us. And next week, we have a case of soft tissue tumor and probable case of thyroid. I will let you know the second case. As of now, this has been confirmed by KM Medical College. The other case will be probably from Indira Hospital.
Okay.
So we will try and sort out. Next week will be two cases, and subsequent week will be another one case. Like that, we are going.
Okay.
And I also request all the senior faculty here to permit their postgraduates to present a case here, number one. And also, if possible, if you can recommend faculty to join us as moderators, please share their numbers. I'll be too glad to call them and speak to them and request them to that, so that we have fresh thoughts and different formats of discussion and verticals. And I thank all of you. And again, I've been informed by many postgraduates that they've been selected by the INISET, the recently published thing. And many of them have got in the second round of the NEET SS also. On behalf of the faculty here, I give my sincere appreciation and congratulations for excellent upcoming career in their choice subspecialty. So with that, with the permission of the senior faculty here,
Sir,
yes, sir, please.
the only correction, I have retired from BJMC. Now I am doing a private, so I am no more attached with the BJMC.
I will
I'll be
mark
more free and
retired,
will
sir.
join more.
Sir,
Sure.
I'll be happy if you are with us all Fridays, sir.
Okay.
Sir, it is a
Just because I have
collaborative and
retired
collective.
on 30th April, completing 62 years.
Sir, happy
Okay.
retired life.
Thank
And
you,
I
sir.
request you to join us all Fridays. And
Okay.
I
Thank you,
wish
sir.
I was told even during the flight accident, you were showing interest in helping all the surgical colleagues to run through the emergency list. That's so very kind of you to get back to the institution for national emergency.
And obviously, I'll be there.
I'm hearing a lot of good work by BJMC, which could save so
It
many
was.
people. And I also give my condolences to the students and the staffs. I was told today 19 people of the BJMC employees and the doctors have passed away,
Yeah.
apart from the aircraft
Yes.
death.
Yes, sir. Yes, sir. It was a
On
real
behalf,
disaster.
On behalf of all the faculty, we
Thank you.
give
Thank you
our
very much.
condolences to the family, sir.
Thank you very
And
much, sir.
the best
Thank you,
wishes
sir.
for the second innings,
Thank you,
sir.
sir.
Okay.
With the
Thank you,
permission
sir.
of the faculty. Thank you, Dr. Vivek. I
Thank
give
you,
my
sir.
kind encourage to your faculty for permitting you. And good luck to you.